just as an additive point, please remember for your newborn babies, please keep them warm and keep them dry. That's going to be the best for preventing hypoglycemia. And I guess next one moving on is newborn resuscitation. The only change in this is we removed umbilical vein cannulation as a procedure. Chip Cooper had done a search via Tempsys, and we found, I believe, 2 patients who had received this, and they were both found to be documentation errors. They were in adults, so they're misdocumented. This procedure is kind of a low-frequency procedure. It's being removed from a lot of state protocols, and with our improvements of having better IO access, we just felt that it was a procedure that's not being used, so it was removed. And obstetrical emergencies is the next protocol. The only real change is routine administration of oxytocin for a mother post-delivery. Before it was an option for postpartum hemorrhage. Now it's just in there to routinely give.
Pain management. I think a lot of paramedics will be happy to see a new bullet for patients that may be experiencing musculoskeletal spasms to call med control for guidance on giving some benzodiazepines for them. Outside of that, I think that there are no changes.
Yeah, we did add just a cautionary flag about ketorolac, just some of the contraindications of that medication, particularly if patients have known renal insufficiency, pregnancy or peptic ulcer disease, just to use that medication with caution, or avoid it, I should say.
Yep, otherwise no significant real changes there at all.
Next are the poisoning, substance abuse overdose protocol. And
yeah, the only changes we made in this protocol was for tricyclic, treating tricyclic overdose. The dose of sodium bicarb was increased to 2 milliequivalents per kilogram from 1. This was recommended by our toxicology medical director of the Poison Control Center. And this also, you'll find throughout the document, it standardizes the dose between cardiac arrests as well. So that dose is kind of the same for all indications.
And then just big pearls in the back of signs and symptoms and some toxidromes on the different types of overdoses. Almost done the medical section.
Likewise, I don't think there's any other significant change for the poisoning / overdose section for pediatrics. For seizures,
There's
no changes.
no changes. Next, septic shock, though, is a new protocol.
Yeah,
Take
so
a minute on that one.
a lot of our EMS systems around the state are developing, and emergency departments are developing sort of sepsis alerts to try to recognize these patients sooner, as early goal directive therapy is sort of key to treating these patients and decreases mortality if we can recognize them early and get IV fluids and antibiotics on board. So this is a new protocol for the state. It's an adult protocol. It starts out with how do we identify possible septic shock, and I'll just read kind of the list real quick. If you suspect an infection, and then you move down to your what we call our SEERS criteria. If you have 2 or more, if they have a fever or they're hypothermic, so if their temperature is less than 96.8 or greater than 100.4, if their heart rate is greater than 90, respiratory rate greater than 20, systolic blood pressure less than 90, or if they have new onset altered mental status or worsening mental status that was previously altered. Some EMS systems are also using pre-hospital lactate levels, and if you get that level and it's greater than 4, if you have 2 or more of those, then you fall into the into this protocol. What this protocol allows is systems to develop.
Just for clarification, not 2 or more elevated lactate levels.
No, I'm sorry, 2 or more of the criteria that I
whole
listed.
criteria.
Correct. Yeah. What this protocol allows is to activate a sepsis alert for some emergency departments that are developing a sepsis pathway. And what's different from the regular shock protocol is the amount of fluid. So this allows the advanced EMT level for a blood pressure less than 90 to give 500 ml boluses. And you could go up to 4 liters of fluid, so quite a lot of fluid. After 2 liters at the paramedic level, that's when they start considering giving their pressors. Norepinephrine is preferred, but whatever they're carrying, they can give, and it's included in the protocol.
Yeah, 2 things. Some literature really in the last few years has suggested that norepinephrine should probably be our preferred pressor of choice. And the other thing to mention about this, if you suspect your patient has septic shock, please let us know as soon as possible. There is a national guideline to try and get antibiotics into these patients within an hour of identifying that they're in septic shock. So the earlier we know about it, the earlier somebody gives us a heads up, if you guys can, ultimately better for the patient.
So the next protocol is a shock protocol. We reintroduced this in 2011, and this time around we've just reformatted it and included the 4 types of shock. So we have the cardiogenic shock in one column, then the distributive, hypovolemic, and obstructive. And I mean, you can just follow down each of those pathways. One thing to note under the hypovolemic, you really shouldn't be giving more than 2 liters of fluid to these patients. Number of reasons, but if you need to go over the 2 liters, talk to medical control first. I mean, putting that much fluid into somebody who's hypovolemic is, you know, our fear of any clotting that's started, that we're going to dilute that and stop that process.
So in the setting of, you know, trauma patient with uncontrolled hemorrhage, there's this concept of permissive hypotension that there's a lot of literature support for. No longer are we really trying to get normal blood pressures out of these patients. Mm-hmm. The higher that blood pressure goes, the more likely you are to dislodge whatever clot might have formed. So oftentimes we consider a systolic blood pressure during the resuscitation phase of 90 to be perfectly adequate. What else?
One of the things I would add is, well, while we're talking about hypovolemic shock or hemorrhagic shock, if you are going to use a tourniquet, commercial tourniquets are preferred. They're not terribly expensive. If you can put that onto your ambulance, it's much, it can save a life, and it's much more effective and better for the patient than trying to make a tourniquet on the scene.
Yeah, the commercial tourniquets exert pressure over a wider zone, so are less likely to cause vascular or neurologic injury than if you were to just simply tie a cord or a rope around the extremity that you're trying to control hemorrhage in.
The same for the pediatric. It applies what we just talked about. Smoke inhalation. This is the protocol for the cyano kit. And the only change that we did here was we found that the cyano kit comes in 2 concentrations now. You can get a vial, a 5-gram vial, or it comes in 2.5-gram vials, both of which need to be administered over 15 minutes. So we've just adjusted the protocol to reflect the 2 different concentrations.
A couple of things to kind of add into that protocol. We are kind of decreasing pre-hospital oxygen use in EMS. We're kind of getting away from putting a non-rebreather on every patient, realizing that hyperoxia may be actually bad for patients, and particularly if you have somebody with COPD or a newborn or somebody suffering from acute coronary syndrome. This is the one protocol if somebody has smoke inhalation where you want to use hypooxygen. So it actually, if they have carbon monoxide exposure, it facilitates carbon dioxide leaving the body quicker, so it'll decrease that half-life. And also a cautionary word for people using the co-oximeters, such as the RAD-57, great devices. Okay for a screening tool, but if somebody has symptoms, even if that device is telling you that their level is low, treat them, and they should be taken to the hospital for an evaluation. Some studies have shown that they can be inaccurate at times.
Not necessarily. If you get a high reading on them, it's great, it's probably high. But if it's low and the patient still has symptoms, that's when I would be suspicious that maybe your reading is falsely low.
Correct, yep.
All right, and the last protocol under the medical protocols is our stroke protocol. Some changes here, or we're trying to really emphasize when the patient was last seen normal. Also completing the pre-hospital stroke scale. And you can see there that it says if any one of these 3 signs is abnormal, the probability of a stroke is at 72%. And so whenever you suspect a patient having a stroke, it's really important that you call the hospital as soon as possible and call in, and we're trying to get the word out to use the word stroke alert, and if we can get that to go statewide, that everybody's using the same terminology, this is better patient care.
And the timeline is important for that. So that's going to be a patient, depending on what you're doing locally, it's anywhere from 3 to 4.5 hours. So find out what your hospital uses. But if they have any of those, you can establish that the last time they were seen normal was less than between that 3 and 4.5 hour range, and they have a positive stroke scale, that's when we can activate the stroke system and activate a stroke alert.
I think it should not be taken lightly. Very oftentimes, I think patients or their families kind of give some unintentionally misleading information about the time of onset of symptoms. Really, you need to drill down with the family and try and sort out exactly when the first time was they either noted the symptoms or when the last time was that they actually saw the person. Not that they heard them get up to go to the bathroom at some point during the night or something like that. Because we really rely on that time to help us determine whether thrombolytics are appropriate or not. If you get too far outside the window, then your risk of causing some sort of intracranial hemorrhage increases greatly. So we are always trying to nail that time down as close as possible. So please do whatever you can to get us a very, very accurate number.
All right, so that ends the medical protocols and will lead us into the cardiac protocols.